Get it. Our meeting started. So it's what time is it? 2:37 p.m. Start of our North Lincoln County Hospital Board meeting today, January the 28th. I'd like to recognize our visitors, quite a bit of staff. Also recognize our representative from SBI, as well as a representative to the legislature, Senator Dockstetter. Appreciate you being here, and I hope you have a fun session. And so we'll see how that goes in Wyoming.
No comment, Senator. No comment.
So we have meetings from the last, moved by Mindy to approve, I assume.
I'll second.
Second by Jeff on the minutes for the November 9th in December. No discussion. Call for vote. All those in favor?
Aye.
Any opposed? Motion passes. Any changes to our agenda for? If not, I would look for a motion to approve the agenda as presented. Second that one. Any discussion on those in favor?
Aye.
Any opposed? Did Abby just walk in?
Yeah.
Are you? This is Tori this time, right? Recognition of star performer?
Yeah. Sadie is on virtually, so she asked me to do this part for her. So, as a reminder, our STAR Awards are given out quarterly now, and so we have anybody that can submit their recognition to our employees for going above and beyond. And we take those, we redact all the names, and our employee engagement committee will go through them and they'll choose who they felt best exemplified all of our qualities here at Star Valley. I will read our
Scott Nell, audit partner on the Star Valley Health Engagement. Coming to you from the Billings, Montana office of Ide Bailey. I turned on the sharing for the slide, so if someone could just confirm that my smiling face is on the screen there.
We are seeing your report to Star Valley Health Board.
Okay. So as was just mentioned, on Monday, I met with the finance committee, took I would say a deeper dive into the results of the audit and the financial statements that I will do here today. I've got a very, very short slide deck. I was asked by the finance committee to do just 5-10 minutes, updating the whole board on the results of the audit. So I'll jump in. Okay, currently the financial statements sit in draft form. We plan to issue the financial statements pending the facility obtaining a waiver from its lender in regards to a violation of a financial covenant and the execution of a forbearance agreement with the lender. Scott, Graham, do you have any insights there? I know we were maybe going to see that forbearance agreement today.
Well, I heard from Mike Mueller at the bank. He had mentioned that they're drafting the forbearance letter, and quote, I am pushing as hard as I can to get this done. That's what I heard on Monday, late afternoon. And so any moment now, I hope that we'll have it by the end of the week for sure. That's what he said.
Fantastic.
So
Thanks.
Scott, we're kind of on hold with First Bank till they get us that letter.
That is
They
correct.
haven't indicated they're not going to provide us the letter. Oops, Scott, I was thinking Scott Graham instead of Scott Nelson. Sorry, Scott Nelson.
The forbearance was approved, he said.
Okay.
I'm just working to draft the agreement and letter.
We don't have the written copy of that. Okay.
I'll have it today, tomorrow, maybe by the end of the week for sure, and then we'll get this issued.
You may not want to commit yourself, but anyway. Go ahead, Scott Nelson.
Scott Graham, thanks for weighing in there. I appreciate it. Just want to highlight a couple areas of audit focus. Tell you a little bit about a new accounting standard that was required to be adopted. Governmental Accounting Standards Board, or what we refer to for short, the GASB, issued a pronouncement regarding compensated absences. GASB 101, as it's also called, has changed how we account for sick leave. Prior audit standards did require an accrual for sick leave if an employee was not paid out upon separation from employment. This new standard requires an estimation process to calculate an accrual for an amount of sick leave to be paid out during an employee's tenure, as long as they remain employed. Accordingly, as a result of adoption of that new standard, an adjustment of $315,000 was added to the compensated absences line item on your statement of net position. I mentioned accounting estimates there. Always a focus of our audit procedures, just because of there's an estimation process there, and there always a degree of subjectivity in formulating those estimates, and present a risk of material misstatement to the financials. Lastly, we certainly give attention to the facility's compliance with the terms and conditions associated with the loan agreements. And as I just mentioned, the facility is in non-compliance with its days cash on hand financial ratio. That is the financial covenant that we are seeking the waiver on from First Bank.
So Scott Nelson, can you tell us the difference? So what is the covenant? And
Sure. Yeah.
Where's our organization in relationship to that covenant?
Okay. So the loan agreement as written requires the facility to have 100 days cash on hand. And just to frame that up, if the cash coming in the bank, if we turned off the spigot today, that's a ratio calculation saying the facility could operate for another 100 days without another dollar coming in the door. So just to give some context there. Because that particular financial covenant was missed also in fiscal 2024, there was a forbearance agreement that dropped that 100 days threshold down to 60. And I believe the actual calculation was 48 or 49 days, so 11 or 12 days short on that ratio calculation.
Okay. Anybody remember? Right. Okay.
I'll just touch briefly here on the significant estimates that are within the financial statements. I would say the two key estimates is one related to the collectability of your accounts receivable. This reserve is certainly the largest and most important estimate within your financials. And an estimate of an amount due to or due from related to your Medicare cost report. Secondarily, as far as importance and significance to the financials, they do contain reserves for any malpractice claims or other types of insurance claims, E&O or whatever the case may be, as well as an accrual for your self-funded employee health insurance liability. So because you are self-funded, have to audit the accrual of the run out of those claims. So claims incurred within the fiscal year that are going to be paid subsequent to year end. And last but not least, there with the adoption of GASB 101 related to compensated absences, there is an estimation process to determine the amount of sick leave that you'll eventually pay out. We've determined that the methodologies used to create the estimates related to the collectability of accounts receivable contains a few errors as we look through that and performed our audit procedures around that particular estimate. However, as adjusted, we believe that not only that particular estimate, along with it, all 5 listed there are fairly stated based on the facts and the circumstances and the audit evidence that we obtained.
So before you go on,
Sure.
go back to that last slide. One of the questions I had that came to my mind as I saw that the self-funded. We're obviously have adequate estimates, but if I remember, we had Big O. I mean, it was more unexpected than higher than we expected. Is that right? Our health insurance costs for claims?
Yes.
And so as they came in, it was way out of budget. So I guess, is that something that's sometimes a little bit of an unknown because of the health of the year? Scott,
Yeah, for sure. To see how the estimates paid subsequent to year end. But as a result of our audit procedures, we did back off the reserves through a proposed adjusting journal entry. So as we received the trial balance, that claims reserve was stronger than it needed to be, if you will. So we were able to reduce the liability and the claims expense on the operation side of things.
Okay. Scott, Graham, do you have anything to add to that?
Yeah, when we did close the books for June, preliminary to give them the trial balance to the auditors, we used estimates from the end of June going forward. So we had about a month's worth of what they call lag payments, which are actual payments related to the prior periods. And then we just used estimates based on the prior year's experience lag after June 30, 2024 to estimate what it might be going forward. By the time Scott and his team got there, of course, we had 2 more months under our belt with actual experience of the lag payments coming in related to that prior period. Which indeed, I mean, when I first did it, I reduced it because it was too high. Discussed this with Scott and his team, and they said, well, looks okay, basically. So when they got here and we finalized, I think the last claims lag report we got was through the end of October. And the claims experience is much better than the prior year. So that's how and it is a 2020, it's a 2020 hindsight. The longer we go, we're still checking it this month to see that the adequacy at June 30, 25 was good. And it is.
So what's the pretty estimate?
It's 2024.
For 2024?
That,
Oh, okay, I was a year off. All right.
and we just had, it was a different at the end of the year related to that policy year before. We're just figured the loss ratios were.
There was liability recorded of $1,631,000 related to that current year Medicare cost report. So nearly half of that hit to the bottom line related to the Medicare cost report. And what that tells you is under the cost-based reimbursement model, the facility was really getting reimbursed better than it should have been once we let the dust settle and filed that cost report. So your reimbursement along the way throughout the year was more than it should have been. So you end up with a liability back to Medicare. It's related to, I guess your net patient receivables. So some adjustments culminated in a reduction to net receivables to the tune of $568,000. I mentioned the adoption of that accounting standard. So that was just kind of a mandatory one that we had to make. So a $315,000 increase to the compensated absences balance, just as a result of the adoption of the accounting standard. And then again, as I just mentioned regarding that self-funded health insurance accrual, we did reduce expense or reduce the liability for those self-funded health insurance claims to the tune of $851,000. I will tell you, in the prior year, we posted 69 adjusting journal entries, so we are seeing improvement. That said, there are still some areas that we feel the accounting could be tightened up, and that is certainly in the area of accounts receivable and setting the reserves against those patient claims. The other area where we incurred significant amount of time was dealing with the accounting for your leasing activity. So facility-wide, there are in excess of 40 leases to account for. At present and at audit time, all the accounting was done in Excel spreadsheets, and it's quite a cumbersome process to do so. So, as auditors, we've made a suggestion to management to either engage us as auditors to utilize our own lease calculation software, or option two, if you will, purchase a lease tracking software to have in-house. My understanding is management has elected to purchase a lease accounting software, and hopefully that one shortens the amount of time from when we start as auditors and being able to issue a report. And I really do feel it would reduce audit costs, because we did incur a significant amount of extra time just dealing with that lease accounting process. So I look forward to better things in the next fiscal year on that front for sure.
So one of the questions that came up on that here with the board, and correct me if it's the wrong question, ladies, is there anything we can do to make that a little more known? And that you just said we're looking at some software. I don't know whether you want to comment, Scott Graham, on going forward with cost reports and that. My understanding is we're taking a significant role in figuring that out. Is that?
Yeah, let's go ahead. Thank you, Mr. Chair. The easy answer on the leases is we have purchased the software. We'll have that implemented as we next month or so. So by the end of the year, for sure, we'll have that easy to audit for them and easy for us to account for cost effectively. On the cost report, we just completed 2 days worth of very, very intense training. All directors and leadership team, managers from the whole facility in this very room, and we learned a lot. There's a lot to learn, and we have a plan in place to be able to estimate that on a monthly basis going forward, and have the methodology and a tool. But it's been challenging for us since the Epic implementation, not to put any blame on that, but it's just been very challenging. We've 2 weeks ago, we had a consultant here from My Daily who helped us significantly in 1 week's time to mend up some of the areas that we had trouble with. And so, and we have a brand new controller who's deep into it now and very, very engaged in making sure that is easily forecasted, measured every month based on what we're actually doing in the most recent months.
So what I hear you say, though, is that the decisions are clear down to manager level that affect how our cost report comes out. I mean, it's throughout the whole organization, I would guess.
Well,
there has to be certain decisions made to make it effective or efficient.
Yeah, more than 50% of our organization's utilization is Medicare patients, Medicare Medicaid patients, and it's increasing. Every expense that we have on the books, since we're a cost reimbursed facility, every expense has potential to be reimbursed or having Medicare participate help us pay us back 100% or 99% to be exact of those costs that qualify. And so each department, they all learned a lot. It was attended by every single one of our people. I don't think anybody missed except one person. And it was very engaging. They were all asking questions because every decision, pretty much, and can chime in here, any significant decision has to have, how will this impact our cost report? And then determine what impact, so we anticipate that going forward. Every department is impacted.
Great, thanks. Was that your question, Mindy, or did I? You didn't really have one. You just mentioned something to me about that.
Scott mentioned it.
Yeah.
Briefly. What we learned today is we shouldn't use the Medicare reimbursement rate as much as maybe we had relied upon.
Yes.
We got a new.
That is true.
Because it was too high, but they placed the rate. They said, here's the rate. When they gave us an interim rate, back in end of June and went into effect July. Every 6 months, basically, you get an updated rate. And that's saying, based on a charge, they reimburse us X percent.
Yeah.
We learned, and just best practices, don't rely on that.
And that only gets reconciled once a year.
Well, it's just like a personal tax return. You do your personal tax return once a year. You try to estimate how much taxes you can owe.
Yeah, it's never been a tax return for me, but yeah.
So the estimate is the reimbursement rate during the year on all our charges that we submit to CMS. They, remit back payments, but in our situation.
If you're too conservative, you get a big fat check back and you're like, well, that would have been nice to use somewhere else. And if you're under conservative, you've got a big bill at the end.
Yeah, I mean, the gentleman who facilitated our training is 25 plus years. He's been a Medicare officer.
Yeah.
Very, very, very assist. The better you do financially, more likely you have to pay. The tougher the years you have, likely you will pay or pay less or get something back. Because it just seems to be the nature of the beast. Although it's much more complicated than that, but it seems to be our lot. So we're very excited about what we've learned and have a lot of takeaways. He's still here till the end of the day, meeting with various department heads that wanted one-on-ones with him. So it's very engaging, and hopefully we'll help.
Jeff?
If you have learned to not rely on those estimates, then what's your methodology in the absence of that?
Great question. So the methodology or tool, it's a tool, not necessarily a methodology, but the tool that we have purchased from iDaily takes the prior year's cost report as a model, they call it the model. And then they use that to overlay what's happening the current year, right? Like they'll use the 2025 cost report as we amend it shortly. We're going to amend it for a couple of items we found that could be corrected. They'll use that as the model, and then we'll use actual results after that and use that and forecasting forward. So that each month we can use one more month's worth of operations, current operations, current Medicare utilization, current charges and expenses to determine what our liability or receivable could be and appropriate account for it. So that is the plan.
And it's only a revenue estimate, correct?
It's a cost reimbursement estimate.
So does the utilization of a really high rate versus a low rate affect in any way what the reimbursement would be?
Not necessarily.
Okay.
The rate from Medicare's estimated rates, again, he said, don't use that too much because generally it's going to be wrong one way or another.
I just wasn't sure if we were overly conservative, if it would harm us in a cost recovery. And I don't think from what you described that would be the case.
But it's clear that we should cost is the name of the game. It's cost plus 1%, plus 2% for sequestration. So it's like 99% of our Medicare eligible costs are reimbursed. So Medicare is not a profitable enterprise for any hospital at all. But we have plenty of commercial business we need to focus on and make sure that our overall profits are acceptable.
Mr. Chair, may I add that
Yes, Dan.
I think management, I think the board, I think it's the surprise factor that everybody's trying to figure out, right? We're gonna have to pay, we're gonna get money, how much, you know, and if we can, one, get the cost report extraordinarily accurate, and then use the iBailey tool to run the current month financial results, I think we can slim down this, you know, how wide the gate swings on these paybacks or, you know, or a cash inflow from the federal government. But this is the hardest part of a critical access hospital, is knowing that you're really running two businesses. You're running a business that will always lose money, that certain expenses are not allowable to be reimbursed by the federal government. And then you're running a business that is more based off of normal business principles, economic principles of revenue minus your expenses, and that's how you make money. And so the organization just has to figure out how to, one, optimize that cost report so we're getting as much as we possibly can from the federal government that's legal. And then number two is we have to still be efficient enough to make money on the commercial side to make up for the deficit of the Medicare population, and then be able to reinvest back into the facility. So we're having discussions with the finance committee about actually having two financial statements that will then be consolidated into one, so that the organization can see what Medicare is looking like and then what the commercial side is looking like. That's really the direction that we're starting to head.
Other questions on this topic? Back to you, Scott Nelson.
Okay, just my last slide here before I'll just open it up to some general questions. Some commentary on findings regarding internal control over financial reporting. I'll mention two of the findings first here. One, we as auditors are asked to prepare the financial statements as opposed to management preparing a complete set of financial statements, including the footnotes, and then us slapping an opinion on those statements. Just as a matter of convenience and expertise, auditors are allowed to prepare those financial statements, but kind of within our own auditing standards, that is by default considered a weakness within financial reporting. Secondly, we have a finding related to segregation of duties within the accounting function. We coined that as limited size of office staff. Specifically in certain, and I would say limited circumstances, we're not always able to see evidence of, say, a secondary review of reconciliations of accounts. Not that it isn't necessarily happening, but it's not documented. And if we can't see it with our own eyes as auditors, there you go. So I would say that the first two findings are very, very common with most all smaller facilities. And I would speculate that 99.9% of the clients that we service have those same two internal control findings. We did propose material audit adjustments to correct misstatements, throughout the course of the audit. So that's kind of a default, or by definition, a deficiency in internal control over financial reporting. And lastly, I'll mention this, that we did notice that the district maintained deposits at a financial institution that were not fully collateralized. Wyoming state law requires all deposits to be collateralized by their respective financial institution that's holding them. As a result, the district was not in compliance with state statutes. What this was is there was a $2 million deposit in a money market account at a local institution that did not have pledged collateral set against it. The good thing there, as soon as management became aware and we alerted them to the situation, that was rectified and corrected. The amounts that were sitting in the money market were brought back into a general checking account that does have a collateralization accompanied with it. And it from further discussion with management, I think it was a case where the bank didn't get a box checked when they made the deposit to provide that collateral, so on and so forth. But as soon as they became aware of it, they corrected it. And with that, I think I will open it up to any just general questions that you would like to pose.
Or any additional questions? I don't see any questions for you, Scott.
Well, I don't think we did very well on the 5 to 10 minutes, Mr. Chair, but
Sorry about that. It's usually my fault.
No, not a problem. I appreciate the opportunity to get in front of you today. Hopefully the rest of the agenda is not too packed, but with that, I think I will sign off.
Thank you.
Thank you, Scott.
Thank you.
All right, take care, everyone.
Take care, thanks. Okay, Finance and Construction Committee report then. And Robbie, your recommendation on the audit, don't we have to do anything on the audit findings as a board?
It's just a draft, right?
Yeah.
So
Once we have the final, then we have to do a
Accepted.
yeah.
an acceptance?
Yeah.
So we wouldn't do that till at least the next meeting, is that correct?
Right.
Okay.
Just a draft.
So we just have a report, and if you want to give a recommendation today, fine. If not, you can reserve that to the next meeting of acceptance or not acceptance.
I mean, it's a draft report, I'll give a draft recommendation, so.
Okay.
I think we wait until that final.
Good.
No, just to go through the rest of the report then, so the Finance Construction Subcommittee did meet this last Monday, the 26th. Then in this meeting, Scott Nelson, who we just heard from, did present the 24-25 audit report and findings to the committee. But in addition to that report, I just thought it would be worth calling out that we did review some benchmark statistics comparing Star Valley Health performance to other Wyoming and Western critical access hospitals. I think there were some positives in terms of patient AR and contractual adjustments. Star Valley Health is outperforming our peers. In days cash on hand, for example, we're below our peers, but that's something that we're aware of and working on. Management also presented the financial results and the statements of position through the month ended December 31st, and I've just prepared a couple of notes of some of the significant items that we discussed in the committee. First off, because we didn't get a chance to meet in December, November's financial performance was considerably lower than the previous month's averages, and with no real identified reasons. But December did see a return to normal with some improvements in nearly every statistical category. Additionally, there were improvements in revenues that came from non-supported sources. The supported sources, by my definition, is the Medicaid and Medicare showing, at least in the month of December, less of a reliance on those revenue streams. And I think Scott Graham had addressed a little bit of that earlier. Days cash on hand at December 31st was reported at 33, which is a decline from November's days cash on hand of 44. Management did represent to the committee that this is expected to be the low point as part of their plan to recovery. And then we also spent some time in that meeting going through a 6-month plan for some recovery, which I'll cover here in just a minute. I think a couple things that management represented that was affecting the days cash on hand that I think is worth the board paying note of. The opt-in note was paid in full. Accounts payable is $1 million lower than the end of month balance for November, which would have been a cash draw. And there was the one-time payment of $1.6 million connected to the cost study true-up. I mentioned, or the auditors mentioned, that they were waiting on a loan covenant forbearance on the days cash on hand. As a condition in providing that forbearance, management did meet with a banking partner to build a 6-month plan, and that plan included a couple of specific things. First, there was specific steps identified that management would be taking to improve a reduction of patient AR balances, bad debt reduction strategies, expense management strategies, and projecting, and then also expecting the cash balances improvements that we've been seeing historically over the past couple of months to continue on over the course of the next 6 months. The management did prepare or present a tiered recovery plan with days cash on hand milestones for each of the 6 months represented in the plan, and had indicated an intention to report progress on that to their banking partner, and that they would provide the committee with that same report for each of those month ends. So, and that plan, again, it's worth just calling out, it was a joint meeting between management and the banking partner. It was acceptable for all parties, and that was at that meeting, and the plan was kind of a condition on providing that forbearance, but it doesn't appear that there's any problems with that. They were involved in the discussion to help reach that agreement, and it sounds like that's already moving forward with First Bank.
Right there a minute, Jeff. Have you guys seen a copy of that? Those that aren't on the committee?
The 6-month plan.
6-month plan for days cash on hand. Did you send these in the board packet?
Yeah, so that 6-month tier is something, it's on that page,
Yeah.
is something that,
You got it right there. Okay.
that management will be reporting on in achieving that.
Okay.
They did set a plan as part of that to achieve a target of 50 days cash on hand at the end of that 6-month period, and I also think it's worth calling out that management represents that they feel they're likely to exceed that target. We also engaged in a discussion with management regarding the allowance for doubtful accounts. There was an increase in the allowance reported at 12/31, but in terms of real dollars, it is closer in line with historical percentage of overall revenues. The increase in reserve doesn't necessarily mean it's non-collectible, but part of the increase in the balance was a change in policy to reserve at 180 days regardless of the patient or their status. It's 180 days out, it's reserved. And I think it's worth also calling out that this is an area of continued monitoring as part of the 6-month plan.
So it's 100% reserve
At 180 days.
at 180?
Self-pay days. Self-pay, patient
Oh,
days.
self-pay, okay.
Total net revenue for the 6 months ended are in line with plan, and with the expense management strategies in place, they also saw an EBITDA that was in excess of plan. But after considering depreciation and non-operating income and expense, Star Valley Health did report a $662,000 net loss year to date, which is about $831,000 below plan. Most of this difference is explained by interest expense that is in excess of plan and is attributable to the timing of engaging in capital leases. Management expects the amount to normalize through the remainder of the year. Then management also provided additional visibility to the subcommittee in regards to the current state of the Rural Healthcare Transformation Grant. Essentially, there's an intent to continue monitoring the program to determine if there are ways for Star Valley Health to participate in the program, with no clear indications as to how to do that as of now. A complete list of disbursements made for December 2025 were presented in the subcommittee, and these, along with the minutes from our meeting, are included in the board packet. And this concludes my report.
Questions of the finance committee that you haven't already? Answers to. Okay,
I did have, sorry,
go ahead.
Mr.
Cindy.
Chairman, I did have one question. So it looks like, so the bills, looks like one of the reports is good, but then the other report for December is in our packet's really odd. It's like, see that? It's like
Talking about this
disbursement, yeah. So you've got like 10 pages of disbursements. It says the date, December 20, and then check, and then it has a check number, and then you've got a whole nother set of that's who it's to and the amount, and so it's all split up, so we don't know what.
You're talking the detailed report, not the
Page number,
summary.
page number 90, or it goes from,
Oh, just making it difficult to read.
yeah, difficult to figure, yeah, difficult to read.
We
Looks
can
like
fix
it's
that
kind
and
of
resend it.
Portrait instead of landscape,
Yeah,
Essentially, yeah, which is a different format than what.
yeah, and
reviewed in the
it
committee.
went from page, let's see, 70 to,
Rather than being 4 columns on a page. it's
right, so
Half
it's
of the
like half of the
information.
information's here and half is on another set of pages, so.
Is that an onboard issue?
We'll just
It's
send
just
you
never been
another
like
one. This
that.
is what mine looks like, so it's
Right,
really.
could be landscape. It should be landscape, I think it got turned portrait anyway, I just, yeah, it makes it
Sounds,
easier.
sounds like the report I saw doesn't have that. It sounds like an onboard when it came onto this software.
Yeah, and that was December,
We'll have to
November's
check
was
that out.
fine, it was just December, so. And it went from, largest bills paid down to, the least amount, and then the November report was different than, anyway, it's just, yeah, maybe it's just him on the onboarding thing,
We ought to check that out, Scott, so
yeah.
that maybe you look at it after it gets on board,
Yeah, we'll do that.
so that we know that we're looking.
Yeah.
One's not as complicated as the other.
Okay.
Would certainly help us as board members.
Which is good, but I wish, and then November's, it's by date instead of like the largest amount and then down, so I don't know. Would just be, I mean, it'd be easier to read if it's more consistent, I guess, is just a, yeah,
I
sorry.
did have a problem with one.
That's the only thing.
So I think standard is to go from the largest amounts to the
Yeah.
smallest.
But November's wasn't, yeah.
Yeah, and
Yep.
so,
One
we're just looking for
was-
some consistency.
And then
Yeah.
I finally did, it was today, and I bet that was.
Okay,
Okay. Anyway,
We'll resubmit the PDF of that.
not a big deal, I just wanted to mention, it's
Yeah,
easy,
nope.
yeah.
good catch.
It's easier to keep track of and read that way.
It is, I agree. That's why we requested it that way.
Do you want a paper copy then with that?
No, it's okay. It's all right. I just thought I'd mention it. So thank you, Andrew.
Any other questions or comments? Okay. Moving on. I don't think we have anything to approve there.
Dr. Carroll?
What's that?
Chief of Staff.
Did I miss? Yeah, next
We
is,
moved everything in.
next is the chief of staff. Verbal report, I gather.
You should go to the windows.
All right, thanks. We're going to start by having a DBT discussion and a chastisement for administration and anybody else who's sat here for 2 days. All right, that's against medical advice.
What's a DVT?
Deep
Deep vein
thrombosis.
Could lead to pulmonary embolism, death, and no meetings that long is worth it. Scott, you said it was great. BS. It's not. So that's against medical advice, all right?
Did they get up and walk around every hour?
I have no idea.
Well, there's also the mental health issues associated with
That's a whole other topic we'll get to. Day and a half, anything longer than 2 hours. There you go. Okay. Somebody is gonna have
I
to.
think the location of the meeting makes a difference on how long I'm willing to tolerate it. Like if it was in Hawaii.
I'll grant you that.
But it was here, so I do agree with you 100%.
I don't know how that makes any difference.
It
It
does,
makes a big difference.
those costs probably would bill out under for the cost report. That's
Go ahead.
Yeah, as I heard here today, somebody will have to explain this to me. This is not for this meeting. Being efficient is a negative thing. Somebody will have to explain that to the medical staff, please. Okay?
We definitely want you to be efficient though,
Uh-huh,
but in
sure.
dealing with the government, that seems to be the
Uh-huh.
the story.
Somebody will have to explain that to me, all right?
The only thing I liked that I heard was to not rely on.
That was comforting.
that.
And I'm speaking to, as, you know, for the whole medical staff, hearing hope and a prayer. That's good. Love that. All right.
You haven't dealt with the government much then, obviously.
Thank heavens, yeah. All right. As we stand here right now, let's give you it's a little bit different report today, but it's important. So physicians in the active category are 34. Physicians in the affiliate category for Star Valley Health are 40. Advanced practice providers, there's 26. Telemedicine providers, including physicians and advanced practice providers, currently 190 is where we're at. Brings up a whole other discussion, not for this meeting, just regarding telemedicine and how to protect Star Valley Health. By way of information, temporary privileges were signed yesterday by me for the hospital nocturnus program to move forward. The go live is next Tuesday, so the 3rd of February. The pediatric program will also start at that time. From a medical staff standpoint, and me specifically, I have a 5-headed approach coming into this year. And so these 5 things I just wanted to go over quickly. So the first one is MEC and credentialing. I want you to know that you should know this, but we'll report it officially here. The credentialing committee and the medical executive committee meet on a monthly basis. We review credentialing, appointments, reappointments, and privileging items. All recommendations that will be brought to you this year and moving forward have been appropriately vetted by the credentialing committee and the medical executive committee and meet the medical staff bylaws and other regulatory requirements. So we'll say that officially to you. So that's the first one, MEC and credentialing. Next is quality and patient safety. Medical staff and the MEC specifically have ongoing reviews. They include our own quality metrics. We continue to focus on, the patient safety, peer review, performance improvement. Opportunities for continued improvement are being addressed through continued established pathways, and other pathways are being developed as we speak. And currently, I'll report I'm unaware of any adverse trends that would require your attention or action as far as board is concerned. Next, number 3 is medical staff recruitment, retention, and engagement. So efforts in the area of recruitment, as we're from medical staff, we are actively involved in that. These are ongoing. We continue to experience challenges due to geography, due to price of homes, etc. We know the challenges we face here. But there's significant effort there. We've got some physicians out there that have been out there for a while without a bite, cardiology being one. That is noteworthy. So, and efforts and results in the area of retention remain stable. And I'll just use that word right now, stable. Efforts and plans in the area of engagement will be a major focus for us in 2026. Number 4, regulatory and compliance. We'll officially report medical staff bylaws, policies, and procedures remaining regarding compliance with or remain in compliance with current and acceptable standards. Any routine updates or clarifications have been addressed appropriately through the MEC and will continue in this appropriate manner. Number 5, physician wellness, professionalism, and collegiality. So these are the areas that will have increased in significant emphasis moving forward in 2026 for us. Specifically, a physician specialist in these areas has been identified and will receive some specialized training and will become significantly involved as it relates to wellness, professionalism, and collegiality, just for our medical staff. Other facilities have that. It's proven to be effective, and we need it here specifically. And so I also have, I know you're all assigned to different committees. I'm happy to provide to you who your physician representative is, so you know who that is. I can get that to Andrew, or however we want to disperse that to you, okay? Moving forward for this year. And
Will they attend those committee meetings?
they're supposed to, absolutely.
You run that through Andrew, so we get a copy.
And I visited with every one of them since January 1st, and there's a whole page of them here. They've all committed to attend. Some of them are repeat offenders for that committee, and they're there for a reason. And so it's important they're there. It's important for the feedback. So, and with that, any questions? What do I have for today?
You made a statement about pediatric.
Yes.
Starts 3 February.
Same day, next Tuesday.
So
Like
the
I
entire
telehealth.
No. What are we talking about? Because I'm behind the game on that.
Mark can clarify it.
Okay.
Yeah, so I don't know, Dr. Kirk, when we started this, as far as looking into this, you'll know that time better than me.
June or July of 2025.
Yeah, where the idea was a nocturnist program for the hospitalists and the pediatric. So specialized, specific individuals could be called. This is an intermittent health program.
During the nighttime.
Just during the nighttime.
I caught the nocturnal part. Okay.
That means night.
Yeah.
And
I appreciate that.
and you're still on Hawaii time. So, and the pediatric will go hand in hand with that. It's been an interesting ride to this point, and we knew it would take a while. It's taken that and a little some, but nonetheless, we're here, and we'll see.
So we've had to get some specific individuals hired that,
No, this is a program that's
this is IHC.
This is
telemedicine.
correct. This is all tele.
That's
Part of that 190 currently are.
So we're kind of beefing up what we already had.
Well, it's serving a more specific purpose for nighttime.
Right.
Yeah, and the pediatric one specifically where needs some additional resources there.
So we have the same hospitalists, but at night they can have help through the telemedicine.
For admissions, for specific nurse questions, yes.
Does your list of totals have like 190 telehealth broken down into department?
I can get that. I don't have that here.
Don't need to know it particularly, but
I can make it up.
a huge chunk of those are radiology.
Oh, no question.
Yeah, just for.
I know Dr. McClure, I mean, we look at 1 million radiology class. Dr. McClure is our credentialing chair.
Yeah.
And so,
Just as people are like, who are these people?
That's
I'm just gonna say a lot of them are radiology.
a significant amount involves MIA. For sure. But when I got that number, so it's a big number. We knew we'd gone through a lot. I didn't know we'd gone through that number. A lot. So.
Well, you go through the process to vet these people, and it'd be interesting to see how much we utilize them, because it's like they're credentialed just in case we use them, but.
Not all of them. Unlike the MIA or the radiology group, we have to, who knows who's on, and so.
We just, we have to have our bases covered.
With the pediatric and hospitalist nocturnist programs, I'm interested to see.
Yeah.
The volume and.
Yeah, but the quality of life for the regular hospitalists is
Mhm.
related to that. That all makes sense.
Mhm.
I'm not concerned about the number, just if other people were
Sure.
like thinking that number seems crazy.
Sure.
It is what it is.
But when I heard you say you vetted them all and everything's good to go.
Well, when I said that, I meant Dr. McClure.
Thanks for your work.
That he has looked at it all. Okay.
One thing I would like to bring up is that you said more specifically like how thorough this process is, but I've been on the credentialing committee for a few years and I felt that protection for multiple years now. So why did you bring it up? You think that something different is happening?
Not at all.
Okay, I don't need it.
Not in that respect. I felt it appropriate to start the year off to just let the board know
How much?
what we are committed to.
Yeah.
As far as the medical staff is concerned.
Yeah.
And so what you're getting, we're gonna represent to you as vetted appropriately.
Yes.
That makes sense?
Yeah, that's what I heard.
Anything else?
Any questions from Dr. Cowan? Thank you for attending and giving us a report.
Thanks.
Dr. Kirk, follow up?
Thank you, Mr. Chairman. So I just wanted to remind folks about the telehospitalist program. So we have 2 full-time hospitalists that take a week on and a week off, covering all the patients that are admitted to the hospital, minus a few that are covered mostly by our general surgeons. This is a program that is an expense. It does not really add to our bottom line per se. But it is a means of, number one, preserving these 2 individuals. The volume of calls at nighttime has gone up. Number 2, it ensures higher quality, particularly with admissions out of the ER, because the emergency room doctors were holding orders for the most part, as compared to actively engaged in starting the process at their hospitals. So just as a reminder as to the purposes of that particular program, and we have to be mindful of many of our providers in this system work here full-time, who have a great deal of responsibilities and call. Trying to engage with those individuals to figure out ways in which again, it's an expense issue, but we have to be very careful about the pros and cons of adding those dollars to the bottom line. But preservation of our providers is very important.
So I assume we're gonna be monitoring that to make sure that it's helpful
Yes, sir.
in the end, right?
Yes. And this is not the first rodeo that Intermountain Health has participated in this program. Thank you, sir.
Good. All right, moving on, we have a consent agenda. Any questions? You've already pretty well asked
Mr.
everything.
Chairman, I do have-
You got other
We have
items?
bills against the district November 25 and bills against the district November 26.
Correct.
2026. November 2026. That hasn't come yet.
It should be December.
December 25
2020. It should be November 2025
and
and
December 2025.
December
right?
2025.
Good catch, man.
Okay.
Yes.
I'm like, wait a minute. Okay.
Yours doesn't say that.
My written one does not.
Mine says bills against district November 25 and November 2026.
We're gonna prospectively just approve those.
No, mine says 2029, sorry.
It does? No, this is the one I printed off from the,
Oh, you know, I
On
updated
board.
it today, I caught that, so I got you.
oh, I printed it today.
I
Before the meeting, you caught it? Okay.
You appreciate both of you catching.
Sorry about
I've
that.
been
Any change?
I've been looking for 2025, 2026 errors, you know?
You're sure to
I'm
find
guessing
one.
you guys were.
No, I'm not. We all do it. I was.
All right, so under the consent agenda, the first 2 bullet points, or 3 bullet points are correct. We're changing bills against the district December 2025. That's what's in the consent agenda, as well as November 2025. Okay. Anybody have any
That's all.
things to pull out of the consent agenda? If not, I would make a motion to approve the consent agenda.
I make a motion that we approve the consent agenda as written.
Have a motion by Clint to approve.
One second.
Have a second by Abby to approve. Any further discussion? All in favor? Any opposed? Motion passes. You want me to hit my gavel every time? I hope not. Okay, I don't see that we have any unfinished business. We're not a new business.
Mr. Chair.
Yes.
I don't know where to insert this, but can I just take a second in this spot right here?
Sure.
Just to give a thanks to the administration and the hospital on behalf of the search and rescue for donating their snowmobiles to us. It's going to be very valuable to have a setup of both ends of the valley. So very much appreciated. Very nice donation.
Our pleasure. And thank you for all the service that search and rescue does, and especially, you know, with the tragedies that you've been having to deal with. Please pass on to your, you know, the group of committed volunteers that, you know, how much we appreciate their efforts.
So when you say snowmobile, it's
Snowmobiles.
snowmobiles.
It's a tow behind.
Yeah, but there's one in both ends of the valley?
Well, so we had one.
Oh, okay.
And so, you know, with a big 4-stroke pulling it, and now we'll be able to have two
One at
separate
either end,
tow
okay.
units at each end of the valley.
That's what hit me, is I didn't realize there were
Yeah.
two in the valley.
Yeah, we use our boathouse in Alpine, got it insulated and keep it heated now to where we
Okay.
have access.
And you find those really convenient during the winter for
Very, very much so.
search and rescue?
Absolutely, yeah. That's how you can get a victim in there plus a caretaker.
So we get, people looking at them quicker. In a lot of cases, I guess.
Hopefully.
Good. All right. Abby, Quality Committee?
My report for quality, we had a nice presentation by Taylor Keene, who works closely with Dr. Green on all things trauma related, and kind of painted the picture that when we need to call in more support, they were catching that most of the time and hitting the metrics as far as getting, you know, declaring a stroke fast enough and getting the imaging that we needed, knowing when to transport people out in a timely way. We're not really looking to up the designation that we have. We're a receiving hospital at this point. We do not have a designation in Alpine yet, and it does seem like that's maybe the next way. So I don't want to be speaking out of turn, but that seemed like, Tori, is that true? Yes, okay, you're the boss on that.
Yes.
Do you agree?
Yeah, may I add?
Yeah.
So, every hospital, every ER in the state has to have a designation. So.
But you're given a little bit of time to beef that up, yeah.
So they'll be here in May to give us our designation.
And I'm not even worried about it, based on the team that we have.
So Alpine is
It doesn't have.
rated separately from Afton, even though they're connected?
Yes, because we don't have 24/7 surgery up there, so we'll have a lower
Gotcha, okay.
Tori, can you also help me since Sadie's remote? The Good Catch Award, which I'm loving, went to Mary. Remember what she did?
Hume in the ED, and I can look it up.
Remember? It was awesome.
It was.
There were quite a few good ones.
Yeah.
I wanted to
The
speak about.
medication.
I can
Oh, Sadie's here. Okay. Yes.
I can share. So there was a medication that was pulled for a patient that was supposed to be transferred. So the medication was pulled by the nurse. It was given to the flight crew. And then the nurse went to scan the medication to document in the medical record. And a warning popped up that said, this is the wrong medication. So she was able to stop the flight medic from giving the medication before it was administered. And there was some process changes. We put different, there was two medications that looked very similar next to each other in the Pyxis, which is where we pulled the meds. So we were able to change those around. So to hopefully help prevent that from happening in the future.
Thanks, Sadie. So pointing out that good catch, but honestly, like the whole series of things that people are bringing up are saving patients from harm or furthering the organization. And so it really helps towards what we're trying to create a culture of, like speaking up and preventing harm rather than like fixing problems that we already caused. So that's exciting to see. Let's see. I would report on the 7 sets of twins that we either have delivered or planning on delivering this year, and that we're at 119 deliveries, which is higher than our highest year by 10 deliveries. So that speaks to some reputation things, and the care people think they can get here, and our babies, all is good. You shelved the process improvement projects. So I see that there's some stuff on here that we really didn't push those off. We didn't talk about
because
those.
we'd already gone.
So I'll defer to that until we have more information. And then Pace Owens talked about moving out of date medications. He got approval to move out of date medications to an area far away from in date. Because you don't get that much money. You get a few cents for returning things, but if for like a serious emergency, we'll have a stock supply of medicines that really, they just have an expiration date, so we don't use them on patients, but we'll have them in case of an emergency. I like it. So as always, the directors are doing a wonderful job tracking these metrics and pushing the limits on, the excellence that they can perform, and so we're grateful for all they do, and that is my report. Any questions?
Any questions for quality? Doesn't look like it. Thank you. Ethics?
Yes, I do have a report.
Okay.
So we met December 11th. And so the care center charges, Sarah is working with Ocean to resolve this issue. There's an issue. Chris, do you remember what the issue is, or Tori?
Yeah.
Okay.
Yeah. So we have semi-private rooms and private rooms. We've discussed this in the past, but it's just a recurring issue within Ocean, because the way Ocean is built, it's automatically dropping that charge for the private room when we can't bill Medicaid a private room. So she's been working with Ocean, and there is a solution now, so that charge won't automatically.
Okay. So it sounds like there's a solution on that, so that's great. HIPAA trends, there was no HIPAA violations. There were 2 policy violations. 1 staff assessed a family member's chart, and 1 staff assessed their own chart. And those have been taken care of and dealt with. The recent survey results from the state of Wyoming, the state came on an EMTALA complaint. We'd already investigated the complaint and found no concerns, and the state comes and reviews more than the complaint, and they did find another case that was of concern. All the investigations that the state conducts are sent to CMS, and CMS will come back with a determination. This could take several months. We probably haven't heard anything back, have we, on that? No? Okay. Technical and executive tabletop. The key takeaways from that were from the after action report were discussed, including insurance coverage, communications, contact lists, and technical considerations. Another tabletop exercise for all department directors and managers will be scheduled in early 2026. Have we scheduled that? Yeah. Okay. And when is that?
That is scheduled for February 9th.
February 9th. Okay. Thank you. Okay.
What? That was a tabletop?
Tabletop. Mm-hmm.
Cybersecurity.
Yeah. And I think we were invited to the last one. Will the board be, or was it just ethics and compliance that came to that? Okay.
Just the committee.
Okay. So we probably will be invited to this next one, February 9th. Okay.
I assume so.
Okay. Artificial intelligence, the EPIC December enhancement pack features were reviewed, including 7 new tools for clinical and billing staff. And then Chris is going to update on the Trezito breach.
Thank you, Mr. Chair. For awareness, we wanted to let you know Trezito is our clearinghouse vendor that we utilize via Ocean, and they had a data incident upon this notification. We were notified that Star Valley Health patients were impacted with that. So Trezito is working with a company to complete all the required notifications, including patient notifications and optional credit monitoring that goes with this situation. So we've done all the things necessary to work with them to take care of that. But
So this was a hack into Ocean?
No, there's a hack into a
Trezito.
vendor of Ocean
Oh.
that handles our clearinghouse, our billing.
Was it ransom or a hack or what? I guess, could I ask?
Sure. To clarify, it was a web portal for eligibility, where an actor gained access and monitored and utilized that web portal. So it wasn't their actual system that was, hacked or breached.
He was able to get into vital information, sounds like.
From that web portal.
Thanks.
Thank you. Thanks, Chris. And that's all I have, Mr. Chairman, on the ethics.
Any questions for me?
Yeah, is it illegal for a patient or an employee of Star Valley Health to access their own chart? Why did that show up on the report? Or is it like, oh, it was their own chart, nobody?
Chris, you want to answer that because there are some specific
Yeah, we talked
guidelines
about
on
that,
that.
yeah, there are specific. I
Did you hear the
I
question,
get the one
Chris?
of looking at
Well,
your family's chart.
Is this a HIPAA?
Yeah, it's a HIPAA, the one I discussed,
Yeah,
yeah.
so Sadie, are you still on?
Yeah, I can answer that. So it's not a HIPAA violation if they're accessing their family's chart with their family's
not family.
permission.
They're asking.
Not the family one, that one seems sketch, looking at their own chart.
Yeah, so that's not a HIPAA violation, but our policy is for us to not use our electronic medical record to look up our own accounts. Because it's a legal document, you run the risk of people going in and changing things in there, which we really don't want to happen. So we just ask them to use my chart. If somebody does access their own chart through Epic, I send them a reminder saying, hey, just so you're aware, this is our policy. Please let me know if you have any issues getting access to my chart or if you have any questions. And then I kind of monitor it to make sure they're not continuing to do it.
I like it, good job. Makes
Thanks,
sense.
Sadie.
Thank you.
Do we have a foundation meeting?
Yeah,
You
go.
Yes, we did.
You got all the
Sean
election
Barrett
stuff,
attended.
yeah.
Oh, Sean attended?
You might be here.
I would be happy to provide a report.
Mike, would you, since Sean hasn't arrived yet? Sean won't be here.
Mr. Chairman, board members, the foundation board did meet earlier this month and conducted business. They are actively advertising for an executive director of the foundation. We're entertaining three what I think are very qualified, hopeful candidates right now. Some local, some not. That have a lot of experience in this type of a realm. So that's exciting. Mr. John Getler has consented to meet with us free of charge to help us go through the applications and give us some feedback on his opinion that we could take or leave.
Just the guy out of Jackson?
Yes, a fellow that has worked with us before.
Okay.
So we'll be doing that in early February, and then conducting interviews probably during the month of February for an executive director of the foundation. The board is very interested in recruiting new board members. We have lost a couple of board members over the last few months that kind of aged out of their terms. Others have decided to stay on and continue to be involved. We'd like to recruit 3 or 4 new board members if we could. So if you have any ideas or thoughts of community members who might be interested, please let me know and we'll contact them and ask them if they would like to attend a meeting and conduct a little interview with the board to see if they're interested in serving. That's really all I had, Mr. Chairman. Other than I would say that the foundation has chosen to sponsor a bowling tournament at Salt River Station on March, the Saturday after state tournaments and the Saturday before spring break. March 19th, something like that. And so we're excited to sponsor that as a foundation. And we're seeking contributors who would be willing to sponsor teams so we can have a good, fun Saturday morning. The the movie theater has consented to also do a free kids movie at the same time from 10 to noon. So kids can attend the movies while parents maybe are bowling. So we're excited to do that event again this year. It's been several years since we've done one of those.
I think we have a volunteer team. Did you have a question?
It's not, no, we have a physician team ready to go.
Oh, nice.
Oh.
Glad to hear it. That's good.
We do have a volunteer team. Sorry.
So you can sponsor the team.
Talk to Dr. McClure.
I am so excited for that. Will you guys live stream? I have a question for you. Are you gonna advertise and stuff? I'm sure the bank would put it, I mean, I know Bank of Starville has done it in the past. Are you gonna advertise or get a hold of us or
Yes,
send something out to us?
I'll be
Okay.
making the rounds to some of the local thriving businesses.
I think the bank's people
Asking them
go
for
after each other.
donation.
It'll help me know who I'm
I
getting
see
next month.
several of you that work for very affluent companies that are going to make
That's
an
good.
effort
I just wanted
get
to.
some sponsorships. And a lot of the vendors that work and do business with Star Valley Health have been very generous over the years, and I think that we'll be able to probably. I think we're looking for, how many lanes are down there? 8. 8. We're looking for 8 sponsors, and it'll be a nominal fee, just enough to cover the charges. This isn't really a fundraising event. The foundation is after. It's more of a let's have some fun in the middle of the winter kind of a thing.
You can advertise as get to know your surgeons.
Yeah, there you go. That's a good idea. Yeah, so just for your information, if you'd like to participate, we'd love it if you would. And we'll serve some lunch during, later in the morning before the end of the event, and give away a few awards for the best bowlers and that kind of thing. So that's really all I have for my foundation report.
Are you suggesting a board team?
Absolutely.
We would like to reserve the bumpers first.
You might qualify in 6 and under.
6 and under.
6 and under.
Clint?
So Mike, on this the foundation,
Executive director.
Executive director, yeah. So what are the top 2 job descriptions that person is getting hired for?
So this is a position that will be funded fully by the foundation. There won't be any unless we determine it makes sense. But as Mr. Urbina and I have talked about this, and as I've talked about with the foundation board members, we feel like a position like I've held in the past, Mark Taylor held most recently, you serving 2 masters. One is the foundation and one is the public relations community liaison for the hospital. And it's really hard to focus on fundraising and donor relationship development if you're thinking about the county fair, if you're thinking about community relations in some way. Now, is there crossover? Absolutely. This person is really going to have to be focused on, and what the board's intent is for this candidate, whoever is selected, would focus on fundraising, donor relationship development, events that would generate some cash for the foundation, and really kickstart our philanthropic fundraising from members of the community. That's really the intent of this position. Any other questions about that? Okay. Thank you very much. Appreciate it.
Appreciate the report. Auxiliary?
Me.
Abby?
We had a robust discussion on menopause. Everybody was really sad Marlon couldn't make it.
Well, it's affected me.
Absolutely, not as much as your wife. It was a timely discussion for the board member in attendance. Anyway, for real though, this is no lie. This does affect half the population eventually. And Dr. Millicent is doing an amazing job at bringing awareness and bringing great resources to the valley. So hopefully she gets a lot of referrals, and maybe women will be nicer to their husbands if they see her for some sort of treatment.
Nice.
Yeah, the hormones. It's like going through what is that called? What was that kid thing? Teenage puberty, yeah. but in reverse. And then I said like potty training.
That's indicating we don't treat them nice now.
No, I said they'll treat you nicer.
Oh, that's nice.
I'm
I didn't
taking
hear that.
accountability for the
I
way that we
heard it
act.
differently than
Yeah,
that, sorry.
yeah. No, you're great. You keep doing you. We'll try to be nicer. Okay, for real. Raise your hand if you went to the bingo night last Valentine's.
Last Valentine's,
A year ago.
It was the party of the year.
it's a hot date.
It is so fun, and this one is extra special, and it's going to be on February 13th, and I would strongly
Friday.
suggest going
13.
13th. We had 150, let's see, is this right? We're planning for 150. I think we had.
We didn't have enough room.
It's like standing room only.
That's
Yeah, we
right.
didn't have enough room left.
Yeah, everybody's wondering if Dan was running for bishop or something. Somebody's like,
Just like going around shaking hands,
is he
kissing
campaigning for
babies.
bishop? I'm like, no, he's fine. I'm like, oh, he's the
Where's
CEO.
this
And
at?
they were like, what? It's at the, yeah, Civic Center.
Civic Center.
Yeah. I'm dead serious. It is the best time, okay?
All right, moving
Yeah.
on.
And then, I'll just say, these gals, they're the best. They were a big presence at the Star Valley Festival of Trees, and so I took the opportunity to thank them because they helped a lot with the part of the festival that I helped with. So we got
Thank
the
you.
pink ladies there. They were bringing treats in and selling treats and helping with lunch service, and that is every. Oh, they held a tea party for the care center, which is a big hit. They do so much good.
Yeah.
Every time you see them, tell them how great they are.
Sweetest ladies.
So that is my
Good.
report.
All right. So on recommendation of our senior surgeon, let's take a 5-minute break.
DBT,
DBT, time for some walking around.
DBT break. Finally, somebody listens. board had in different areas highlights of what we've been able to accomplish this past year. And sometimes we forget about some of the amazing things that an organization has been able to accomplish and do. And I wanted to recognize Tori. Tori did a fantastic exercise with her direct reports where she sat down with them and they did this exercise. And I liked it so much that I said, hey, Tori, let's do that. Let's carry this over and communicate it with department directors and board members. And I think it's a good exercise, especially as we start to enter into our strategic planning sessions, that we understand where we've come from, where we are now, and then where we need to go. So I'm not going to go into detail with every single item. It's there for your review, but there are, without question, there has been some historic growth and expanded access to care. There's new services and new opportunities. Dr. Cowan talked about quality, safety, and trust, and how we're trying to enhance that culture, investing in our people, and then resilience through challenge. And I want to give just tremendous credit to all of our employees. The call to action by our employees in a lot of different areas has been phenomenal. And you couldn't ask for a better crew to work with than the people here at Star Valley Health. The medical staff is the best I've ever worked with. They care greatly about the community, about the organization. They're trying to figure out how to move things forward, and so there's very good alignment between the medical staff and administration. And again, every organization has challenges. It's how you deal with those challenges that really defines your culture, and we're very grateful for this board, for your listening ears, for your understanding, for you asking questions and helping provide guidance to us. Because without that alignment from the board to administration and the medical staff to department directors and all of our other employees, we wouldn't be able to accomplish what we have been able to accomplish. And so we're extraordinarily grateful for each of you as we look back at all of these wonderful accomplishments in 2025. With that being said, let me now pivot to some of the maybe areas that we need to have a little bit more discussion on. We did complete entering into an agreement with Blue Cross Blue Shield of Wyoming for a Medicare Advantage product to take the place of United Healthcare as they exited the market in 2026. I think there's a lot of people in the community that are grateful that we did this. It is, as you're well aware, Medicare reimbursement is you're not going to make money. And but we also know that from now until the next 5 to 10 years, this Medicare population is going to grow in our area, and we have to have the services and the wherewithal to be able to take care of them. Otherwise, they're just going to have to leave the area. So we feel it's aligned with our mission, and we entered into that agreement, and we feel good about the terms that Blue Cross Blue Shield offered. And I'm glad that they're in that space because they're more of a local insurance product that we can have conversations with. The big beautiful bill, the big takeaway, $205 million was awarded by the federal government per year for the next 5 years. 70% of that $205 million per year is going to be put in a trust fund.
So that's the amount that goes to Wyoming.
Yep. Yeah. To Wyoming. And that trust fund is meant to allow for funding of
projects, healthcare investment in perpetuity. I really don't know if that's actually going to happen after the legislature gets a hold of all of this. We'll have to wait until after the session to really see where things fall out. But what we're being told by the Department of Health is that requests for proposal will probably start happening after the legislative session in March, April. And then they're going to be looking at kicking off projects come July. And we'll start to see whether or not we are eligible and aligned with any of those funds to help us with our initiatives here locally. Any questions about rural health transformation dollars? A lot more question marks than answers right now, but they're coming slowly. Okay.
Well, it still leaves, what, 60 odd million a year for projects?
It's a one-time payout, so most of it goes into a trust.
It's not it's one time each
Per
year.
year.
Yeah,
How many years?
Per year.
205 million per year
Per
for
year,
5
for
years.
5 years.
So it's $1 billion.
Like money comes in.
Your
It's
taxes.
a deal, our taxes, yeah.
You get to pay it every year.
I know, it's true.
Mr. Chair, so it was presented to us, the goal is, on the behalf of the state of Wyoming, is to get this endowment built up to where it's self-generating about 30 million a year, I think.
Yeah, then they spend that off the revenues. That's
Yeah,
it.
so-
One stays the same and then you,
Yeah, which I
then
think is a great idea.
it is a great idea.
There might be some debate of whether or not, politicians like to see those dollars at work right now so they can get some political capital, built up with voters. And I don't know how that's all going to, I'll leave that up to the politicians, but we'll just stay in tune at the table and making sure that we're aware of where there might be some opportunities.
Seems like in my reading, state of Wyoming's investments in various funds exceeded any other revenues. Is that correct in that, Mike? So that's that rainy day fund they put
Yes, and
billions away
the
at
state
Maine.
treasurer's office will manage this fund as well.
So they made like $1 billion off of just the investment side to go into general funds. So putting it away is not an unusual thing for Wyoming. Probably good to look for. So we'll see how it works. Great, thanks, Dan.
Okay. Talked about the telenocturnus program in February. We're looking at teleneurology here, coming down the road. I put down interventional radiology in April. I need to put a question mark. I need to revise my statement. I think there's some question marks on the field for OCHN for interventional radiology. So more to come on that. But just wanted to make sure the board's aware of additional services that we're bringing to the community so that the physicians have easier access to refer patients that need certain services, and we can provide them right here locally. And Dr. Cowan is absolutely correct. Telemedicine is, in my opinion, the most justifiable, reliable, and hard evidence approach to helping rural medicine. With hands down. Would you agree with that question as far as transformation of healthcare?
Yeah, it's where we have to go, right?
Yeah.
I think some of the durability may be in question.
Okay, fair.
Yeah. What do you mean by durability?
Yeah. Ooh, how long you got?
30 seconds.
Dr. McClure, go.
So I have concerns about telehealth, and I'm sorry, I didn't come prepared to address you all, but I will say that I have just some concerns that we probably ought to consider as we look at telehealth, in that those are not people who are here.
Mm-hmm.
And in reviewing the history of some of the telehealth providers that we are looking at, it becomes apparent that there are a lot of potential risks that we may not be considering fully, both risks to the organization and risks to individual physicians who participate in the care of patients who are not actually seeing life.
Very good, valid point. It's not, I don't want to present that it's a perfect system, right? But it is something that is where we might not be able to have, you know, the number of staff necessary to cover every single specialty. This is a way that we should approach it, but we should do it with eyes wide open. I think that's what I'm hearing from you, Dr. McClure. Is that correct?
So durability is lasting, you're saying?
I will answer it this way. Cody Health is on their third group of nocturnists in 3 years.
Of people actually on site or their telehealth?
Telehealth.
So
I understand what your durability is. I think it's a matter of, will they really meet our test in the end and be effective?
that's the question for any organization as you go into these types of.
You can't do it just off interview. You got to have some experience with it.
Right.
So the great thing about, you know, here we are trying to solve issues, right? And the physicians, they offer a very healthy perspective, and sometimes it's a very skeptical perspective, right? I mean, they're the ones that have to, the ones that live here are treating the patients that they have to see in the grocery store, at church, you know, here in the hospital, and so that they're the ones to answer for it, right? So I think those comments are very well grounded in realism when it comes to telehealth.
You know, one of the things that's beautiful about a smaller institution like this is if I'm referring to somebody, I know that person. They need pain management. I trust Brian McClure implicitly. And it's just tough. It's a name, it's a video, it's somewhat impersonal. And that's difficult at times for a physician. So
I assume that's why we don't see telehealth with like family medicine as much in Star Valley or rural health. I mean,
some areas,
what I hear, they would rather see the patients because if you can't really tell a lot about or everything about a patient if all you're doing is seeing a screen.
Sure. But there's some areas that are, focusing primary care that way. That's the way a patient will get access.
Yeah. No,
is it perfect? No. Goodness, no.
Yeah.
I just, for what it's worth, I do think it's worth at least, I think like you said, Dan, still exploring, finding ways to still figure out how to get a solution that does work, because I mean, isn't that like the number one rule of small business? You sell people what they want, not what they need. And I think if you don't have it as an offering, if you don't have a way of incorporating into what you do, it's just one reason why customers would maybe go elsewhere. I say customers, patients. Yep. It's a reason why they might go elsewhere. So I do think I agree with everything that's being said in terms of the quality of the care, but I think it's probably still worth not giving up on it and exploring how to integrate it.
Very well stated. We want the board to know that we're very serious as an organization to get our days cash on hand back where it should be. We know that the future of Star Valley Health depends on our liquidity resilience. And so the organization is fully aligned. We have rolled out initiatives. We're going to continue to roll out initiatives, and we'll update the board on a regular basis about our, phase one was stabilizing the organization. Phase two now is strengthening the organization. And we've accomplished a lot in phase one. Now the next thing that we have to prove to ourselves and prove to the community is, hey, we're gonna be here for a while because of our financial resilience. So building reserves is really the #1 priority for the organization right now from a financial perspective. We don't want to lose sight of the quality and safety and the services and the growth. All of those are important. But even our cost report initiatives are to make sure that we can manage these swings in cash flow and eliminate those surprises as we move forward. The Gallup Employee Engagement Survey is currently open. It'll close here in a few days, and we'll have those results back to report to the board, and also initiating the training and the action plans to, again, make sure that our employees are highly engaged at our organization. Wanted to let you know that a very robust meeting took place last Thursday with many of the elected officials in the Valley surrounding EMS. That was our 3rd meeting. With that meeting, we agreed as a group with the town of Star Valley Ranch really kind of abstaining because they needed more information. To really seriously consider and move forward with presenting to the community an EMS district. And so the board will see us take measures to see if we can educate the community on the why EMS is essential, even though it's not legally deemed essential by the state, but that we need to give the community an opportunity to have skin in the game and to understand that this is something that Star Valley Health got involved in to save it and to prop it up, and we want to make sure that this is a conversation that is on the front of people's minds. Even if this is a dismal failure in trying to do this, it still allows to give people the opportunity to decide whether or not or to what extent those services should look like. And so I'm very pleased that the group has come together, and we're going to be getting resolutions from each of the towns in support of this. We have scheduled the time with the county commissioners in February, correct, Mike? So we're on the schedule there. I still have to talk to Brandon about whether or not it's impossible to hit the August deadline. If not, we're going to shoot for November. I am in conversation still with South Lincoln about them joining and this becoming a county-wide district, not just the northern part of the county. So there's still some moving parts, but wanted the board to know that is an important initiative. We did redo the numbers, and we looked at the most recent reimbursement and the most recent expenses with the adjustments that we made this past year, and it's improved. So the financial loss has improved. Right now, we are subsidizing EMS to the tune of $1.5 million.
That's better than 2.1.
Yep, that's the new number. Okay, so even our hospital levy doesn't cover that. So it's still significant, and so we're going to do this in a very measured way. I know that this can be a very charged conversation for people. I think we have to allow for sentiments around EMS and property taxes and the like. I know that there's a lot of folks, but I do want to trying to position the dialogue and the conversation with just facts and try to make sure that there's more reason involved than feeling. But I don't want to discount how people feel one way or the other. But this is an important topic. We don't know really how the state is going to help prop up EMS. We have some proposals on the table, but I don't believe that it's going to solve a $1.5 million deficit. I do think that healthcare solutions have to be solved locally, not to rely on the federal government or the state government to solve your problems. I feel that way about this hospital, that it should be financially independent. You've heard me say, heck, if there was a way that we could just, give back the property taxes, we would. And hopefully we can get into a situation where we feel really confident that that could happen. But years like this, you're not complaining about a hospital tax levy, right? So I share all this with you because these are some of the thoughts that we need to be prepared as an organization, as we have conversations with community leaders, and as we move forward with this, that this is something that does need to be solved in our area of the state. And if we can do it, it'll make a huge difference. Now, the other thing that I will point out, I am very skeptical that the hospital can completely remove itself from EMS.
Say that one more time.
I'm very skeptical that the hospital in the long term can completely remove itself from EMS. Here's why. It's the reimbursement that we receive. So we get cost-based reimbursement for Medicare, and then we have favorable managed care contracts for insurance companies. That $1.5 million deficit has a lot. I mean, it would be, if we continue with the existing services, it would be way more significant if the hospital were not used, if the EMS was not utilizing hospital reimbursement. So we're going to have to construct this in such a way where we are a partner financially with EMS in perpetuity.
Yeah, quick question or comments. First off, I mean, it sounds like a great use of the Rural Health Transformation Act to be able to help across the state, help see the EMS services continue. But secondly, I'm just wondering, what was the tone in that meeting? If you're looking for some sort of funding through ballot measure, I mean, was there a feeling that there was a likelihood of some sort of pass? Or because as a resident living out in the community, the attitudes toward taxes, it just feels like that this would be dead in the water. And I'm wondering if that's the case. Is it still a victory for the conversation that would happen? And if it doesn't, then what's the, I guess maybe it's too early to talk about what the fallback plan is. But
so I think generally everybody that lives in the valley knows that property taxes it's a non-starter. I mean, let's just start there. Okay. I mean, the elected officials know it. We know it. It's not like we're starting with hey, 100% we're going to win this game. That is not the starting point. The starting point is everybody realizing, holy cow, there really isn't any other option to make this sustainable. We have looked at it. We have discussed sales tax. We have, 6 penny tax. We discussed all sorts of different things that say, can the county do it? Can the towns do it? Nobody has the dollars. Nobody. And nobody's going to raise their hand and say, hey, we'll solve the problem. So I think it is this tension of property taxes, non-starter, EMS, it's important. And we're going to let those two competing ideas collide in the public.
and allow for public debate, allow for folks to be educated. And like I said, I told the group, I said, hey, we're going to give this a good college try. If it's an abject failure, it's really not. Why?
People had a discussion.
That's exactly right. So if at the end of the day, we have raised awareness, we've given the public an opportunity to fund EMS, and then if this organization has to make some difficult decisions about EMS,
Everybody had a say in it,
Yeah,
and they voted yes or no.
there.
Can I ask a couple questions?
go ahead.
Is your intention to have, what are we calling that district?
Just
EMS?
EMS
Is
district.
it your intention that those funds also go to the hospital, or do you create a
No.
different district?
We'd create a
EMS district.
Yeah, separate governance.
Yeah.
We
So in my mind, we have the staffing with,
they would lease everything from us.
they would even lease our employees.
Yep. So what we would
I
do.
just like the idea of having controlled personnel so we can have that high standard of employees, but logistically, like when there's an accident in Alpine, and so then somebody comes from Afton, you can't have an individual city in this little of a town managing their own, because we're sharing ambulances up and down, unless each city thinks they can have 3 ambulances ready
It's
to
not
go.
gonna be an individual.
Yeah, I know, that's why it's a beautiful idea, but I was just curious if you were definitely trying to stay out of it, so people aren't like, well, we don't like what the hospital does with our money anyway already.
Yeah, well.
So you're solving a huge
Yeah.
problem there. It's not like if you're just wanting the money yourself, you
No,
only
no.
take 3 mils of a potential 7 mil that the hospital could require.
All I care about is that this community has a sustainability pathway for what I deem as an essential service, even though legally it's
Plus you
not.
had a multitude of people with their opinions to share, representing each town. They get to be advocates in their own towns. And I hate taxes, but this is something that I would vote yes for. So,
Yeah.
I'm a hard sale, and I would even say yes to this. So, I would.
Great.
Good.
So I think the only thing we have to, before this gets too far, I think we're gonna hear in February, maybe in mid-March, there may be no taxes for districts by the time we get done with the legislature.
Well,
At least that's what I'm
Exactly.
reading. in
well,
local
you know,
papers.
and this is a changing landscape, right?
So I think we need to find, I mean, we're gonna see what happens there before we charge.
Without question, guys,
What replaces that?
Nobody has that answer right now.
I recognize that,
Serious trouble.
you think you have a good game plan when you get in the ring until you get knocked in the mouth, right? And so we're planning on being ready for that first punch, right? Okay, well, we now have to rethink how we're gonna do things, but based off of the facts and circumstances right now,
Yeah.
this is the direction.
Clint,
Yeah, a couple things. So, who's taking the lead on this? Let's create a district and present it to the community. Like, it's gonna take some advertising dollars. It's a
Great question.
We should put search and rescue on that.
Who's in charge?
They have a really good, people really like you guys.
So it's a great question. So we've involved our attorneys, our great attorneys, and,
Lawyers, yeah, stick it on the lawyers.
and really, in order for this education, there does have to be some separation between the hospital and the community. And so we are looking at a not-for-profit organization with maybe some seed money from the foundation and any other donations that might be out there to start the education, the conversation process. Obviously, our role and as employees of Star Valley Health, we have to side, we're fine with education, not promotion.
Yeah.
Does that make sense?
Yep.
There is that distinction. So we're safe legally in the realm of education. So I can educate my, when I have conversations with community members, when I have conversations with our employees, I can educate. And, but I can say, vote yes.
No lie though, search and rescue should be affected by this, right? It's an emergency medical service.
We see it as a very vital partnership having EMS. So second thing is, back to your statement on, and this is just so I can help educate others that talk to me about it. You mentioned something about the EMS relationship to the hospital, the reimbursement. Do they get more favorable reimbursements because they're under us, and they wouldn't if they were a standalone?
That's exactly right.
They wouldn't get as favorable.
There is a significant advantage by one, the cost basis reimbursement from Medicare, and two is the favorable insurance contracts that we've negotiated.
Right. And then this is my
which is a double-edged sword.
I get of why I like this, because once this conversation's had, then it's on the public. They got to decide. You didn't have to decide. The town mayor of Athens didn't have to decide. The public said, no, let's do it. That's on them. Right?
Exactly.
I just think that's really what has to happen is for the community to say, okay, you know what, we don't want property taxes for EMS. Well, that's a decision. And I will say this, there are folks that are saying this is the hospital's responsibility. Okay, if you look at a hospital district, EMS is not part of the hospital's. Okay, we stepped in because we needed to and we had to, and it was the right thing to do. Now, part two to all of this is, well, we can't do this in perpetuity if you want a hospital, right? We just went through a cost report training that those dollars, tax dollars, we don't get any cost reimbursement for OB, and we had 120 deliveries. Why don't we get any Medicare cost reimbursement for OB?
Zero?
There's no Medicare patients.
We're talking about menopause.
Right.
We're just gonna tie it all together. Menopause, Medicare, OB. It just doesn't compute, right? And so all of those.
That was a trick question.
Yeah.
Medicare, yeah.
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 So all of those
I
costs.
get the Medicare thing, but Medicaid.
Medicaid, but not Medicare.
Yeah.
Trying to get a Medicare.
You are trying to trick me.
Yeah, sorry. So the reason, so everything, if we're gonna have an OB service here, it comes from, not the Medicare, but it comes from those commercial contracts and the margin that we make to fund those services. So this is figuring out how to balance everything and come up with funding sources so that this symbiotic, and really it's an ecosystem where we're trying to keep things in balance so that people have good health care. You can't have OB without anesthesia. You can't have, so a lot of times people want to fragment the system and say, this is the only thing that's important. And they just don't understand the causal connection that exists, with the healthcare system as a whole. So I want the board to know that's where we are, that's what our next steps are, and we will see what happens.
Okay, any other questions for Dan?
Sorry,
Jeff.
one quick one. You explained, which I think is right. You can be involved in education, but not necessarily telling people which way to vote. Is there any guidance for board members on that as well? Should we also abstain from opinions one way?
Just take that same approach.
As a board.
Yeah.
It'll depend on, we can't do it any different, but you as an individual, you can give your own opinion about things, right?
Sure. There's a nuance, right? When you're acting in your official capacity as a trustee, it's educational, right? But of course, you still have the ability. You could post on Facebook as an individual and say, I support this, right?
Say no, or you can say no. You can say, Jeff, you know what? Property taxes, I hate them and death to them. And even though the hospital is promoting this, I personally disagree with it.
As a board member, I'm in favor, but personally, I really am not.
I'm too conflict avoidance, I guess. I don't think the public can differentiate between them.
And that's the challenge that you run, right?
You ask them what hat they want you to wear for the answer to the question.
You may want to just figure out, I have my own opinion and I just choose not to share it. Anyway,
All right, so,
anything else?
yeah, the last thing is Mike and I were gonna be doing a radio interview on February the 2nd, just to update the community on the status of the hospital. Just give some good talking points. People I think are curious, hey, how's the hospital doing? So we're gonna provide that update and hope to make you proud.
You gonna have another town meeting with call-ins and that?
I think eventually we would. I do want to get to a position with days cash on hand to just, thank the community. Here's what's happened over the past year. I want to give it a little bit more time to bake. I also would love to be able to use that forum for some education on some other things. But I think, those town halls, we should be doing them on a regular basis but let's give it a little more time.
Okay. FYI, we already talked about the bingo, strategic planning. Hopefully everybody has it in March instead of February. It was once talked about in February, right?
The board meeting will be in.
And the board meeting will be first on that day. And I believe we're meeting in
West, right?
We're still meeting in Thane.
Forever West. Yeah.
Yeah. So kind of plan your whole day down in the lovely village of Thane. Last one was you should have seen your committee assignments. There's a handout here today as well as Andrea has given you those in the past. Any questions on any of that? Let me know. Okay. With that, do we need another 5-minute break? Anybody?
Chris needs a minute to.
We needed some time to set up for, so executive session is going to go like this time. We're going to go in and have our regular people in executive session through all of it until we get down to personnel. Then we're going to excuse most of you and we have some items to discuss under personnel as a board.
Then I have my one.
Well, that's right. Right before that, we'll have you.
One contract issue.
Okay. You want to do that right before we send everybody away?
Yeah,
Okay.
because you're gonna have to send me away too.
Yes. Okay. Anything else? So, I need a motion to go into executive session.
So moved.
Second, Abby has a motion for.
Oh, yeah.
For
So
the
go
item.
into executive session for the purpose of real estate, personnel, litigation.
And other business.
I said that. I felt good about that. Okay, those things.
And I believe Andrea has that and she'll.
Make it
straighten
ready,
it right
okay?
out.
Make it exactly what you want it to
Okay,
say.
is that your second?
Yes.
So we have a motion and a second to go into executive session for appropriate items. All those, any discussion, all those in favor?
Aye.
Any opposed? Okay. How long do you need?
Like 2 minutes.
You just let us know. So we have a short break until Chris lets us know that we're ready to be in executive session.